So I think we'll start. I'd like to welcome all attendees to today's webinar, an introduction to CAS II. CAS II is the latest version of the Cognistat Assessment System, which is the computer-based version of the original Cognistat paper and pencil test. This presentation is aimed at both new and existing Cognistat users. In the next 30 minutes, we'll provide an overview of CAS II, and there will be time for discussion at the end, and you will be invited to type your questions in the text box during the webinar for later presentation to our speakers. I also ask that our guests mute their microphones until the end of the presentation. We are fortunate to have as our speakers today Drs. Jonathan Mueller and Ralph Kiernan, who are the authors of the original paper and pencil test and who've played a large role in the crafting of the Cognistat Assessment System. Dr. Kiernan has a PhD in clinical neuropsychology and maintains a practice in the San Francisco area. He specializes in the evaluation and treatment of patients with mild traumatic brain injury and dementia. Dr. Mueller is a neuropsychiatrist who has separate board certifications in neurology and psychiatry. He is a clinical professor of psychiatry at the University of California at San Francisco School of Medicine and maintains a large private practice. He specializes in the clinical evaluation and treatment of patients with stroke, traumatic brain injury, and dementia, including forensic neuropsychiatry and the assessment of testamentary capacity in a medical legal setting. And so I would turn over the presentation to Dr. Kiernan.
Thank you, Richard. I'm delighted to be here today and talk with you all about CAS II, a system that I'm proud of, and to discuss this revised version of the original Cognistat Assessment System and introduce you to the MCI Index, which is a special scale that we've created that I believe is the best indication of the onset of the early stages of dementia that exists at this point, certainly in a screening examination. So Dr. Mueller and I will be going in and out of various slides and presenting this jointly as we go. So with that, I'd like the next slide. Dr. Mueller?
Good morning. I too am in the San Francisco Bay Area, and I have over the past 20 years worked with a number of neuropsychologists. It's been my great pleasure and privilege to do so. In the field of medicine, as one reviews records of patients who come to one, what one sees most often is that there are cognitive screening tests that are employed, and the three most frequently used are the Mini Mental State, the MoCA, and the St. Louis University Mental Status Examination. It would not be an overstatement to say that thousands, if not tens of thousands, of mini mental state examinations are given every day in North America. Now, these kinds of tests share an approach that samples a number of cognitive domains and then places the results into a hopper of sorts where one is presented with a global or composite score on a 30-point basis. There is something very simple and attractive about this, particularly to physicians who are used to looking at laboratory reports that tell them what a patient's blood glucose is, what a serum sodium is, or what a PSA might be. But the downside of this, of course, is that strengths in one area may be erased by weaknesses in others and vice versa. For our purposes today, what I'd like to say is that none of these tests is sensitive enough to detect the early stages of mild cognitive impairment. By contrast, CAS II provides a graded measure of the earliest stages of cognitive decline and describes and captures this with an MCI index. As such, it identifies a spectrum of impairments within MCI. Next slide, please. I'd like to point out 5 things that Cognistat does that allows it to deliver an individualized approach to cognitive screening. First, it avoids the reliance on global sum scores, which clearly consists of mixing apples and oranges. Instead, it provides specific scores in several cognitive domains, as well as graded measures of subtests within several of those domains. As an example, Cognistat looks at not simply language in terms of word-finding difficulty, but rather it looks at comprehension, repetition, and naming, each with a graded measure that in some ways is analogous to what people in occupational therapy and rehab medicine refer to as FIMS, functional independence measures. So there are clear and direct translations from Cognistat to functional abilities and or limitations that a person may have following a stroke, a head injury, or some other condition that brings the person into acute or subacute rehab. The next thing that Cognistat and CAS offers is that it alerts clinicians to both the presence and the importance of more than a dozen separate factors, each of which can impact the person's ability to cooperate with testing. And what I find particularly interesting is that there is a temptation on the part of some neuropsychologists to view these factors, pain, depression, sleep deprivation, as something that represents a kind of irritant or background noise that simply makes the testing less valid. From a physician's point of view, each of the factors identified represents an important opportunity for intervention and treatment. And I'm going to return to this a little later. The fourth thing on this list is that Cognistat looks at a number of categories of CNS-active medications that have the potential to impact test performance, and we'll return to this later in a few slides. The last thing is we think it's important that every instance of cognitive screening be done in a meaningful historical background and context. We want to know whether a person has a history of schizophrenia for 20 years, whether a person has had 3 heart attacks, whether a person has been in a coma for a month. These things are all important as we try to understand our patient. Next slide, please. We move now to some of the specific Cognistat factors. And here we basically identify 14 different factors, each of which, again, has the ability to interfere with, gum up, complicate, or make difficult the interpretation of tests. And the great risk here, of course, is that if one or more of these factors is present, an examiner may conclude that a person has a brain disorder when in fact they have a treatable, reversible condition. So we're talking here about the problem of false positives. You know, to just look at some of the examples, significant sleep deprivation in an ICU, or a person with years of sleep apnea syndrome, someone who's not wearing his hearing aids to the assessment, or a person who is in significant pain. All of these can impact attention and concentration. Let's move to the next slide.
Okay, I'll take this one. This is the welcome screen that any user of the Cognistat Assessment System first sees when they sign online to run a test. And right at the heart is the button that says Run Test, so that it's quick and easy to start with a new patient. But there's also other options for looking at reference profiles, getting and reviewing your total patient list that you in data storage, reviewing prior test performances on given patients, and changing user settings so that the user of CAS is in a strong position to not only monitor what goes on, but to embed the test results in a record-keeping system. Next slide, please. CAS is computer assisted. It's not a computerized test that the patient sits in front of a terminal to take. Cognitive testing with a patient in front of a terminal is always questionable because of the interface problems that can come up with both normal and normally anxious and impaired patients. What happens with a patient in front of the computer, it brings in an unknown factor so that the scores you obtain are no longer as clearly indicative of what it is you want to measure. CAS is clinician administered. The clinician is using the computer terminal and working and administering the test to the patient as he or she would ordinarily administer it in the traditional sense of cognitive testing. But enjoying the benefit of having automated scoring, automated profiling, having the results automatically stored in an electronic record-keeping system, and receiving the benefit of guidance along the way. If a patient, for example, has trouble with registering the 4 words for the memory test, a caution statement will come up, not to the patient, but to the clinician to say, this may impact the test performance and be careful with your interpretation. Next slide, please. This is a typical pattern for dementia. As you know, dementia can present in many ways, so it's not the only way it might impact Cognistat, but this is typical. And I'll go through the various subtests. The patients are alert under level of consciousness, but they may have varying degrees of problems showing orientation, usually because of memory impairment. There may be a slight decline on the attention subtest, but it need not be very much, especially in the early stages of a dementia. Language functions may be a little off, usually because of attentional problems, but they tend to stay within the normal or average range. Many dementias, however, have impairment in confrontational naming, and you see this particular case has a mild problem in that area. The 2 most sensitive subtests to dementia are constructions and memory, and you see that they lead the way in indicating moderate to severe impairment in this particular case. Calculations may or may not show impairment, and that's also true of the 2 reasoning subtests, similarities and judgment. Next slide, please. John?
Yes. We're now looking at an interesting inpatient. This is a 56-year-old man who had a history of liver disease and came into the hospital for a surgical procedure. Inadvertently, his protein-restricted diet was discontinued. 48 hours after admission, he became agitated and uncooperative with nurses. This led to a request for a psychiatric consultation, and the psychiatrist thought that the person had a dementia with affective lability. When Cognistat was administered on the first occasion, one sees the person's performance reflected in the red line. What happened after that is that the medical records were looked at more carefully, and it was determined that this person needed to be back on a protein-restricted diet. He was given something called lactulose, and 2 days after that happened, he was retested, and that is reflected and captured in the blue line. The importance of this is that cognitive status profiles are really snapshots. They reflect a fluid, emergent picture that is impacted by a number of shifting factors. This slide in and of itself, I think, has tremendous relevance for all of medicine, and particularly for rehab medicine, because what we'd like to be able to demonstrate is that following baseline testing and treatment in a variety of ways, a person's cognition can actually improve. One could also imagine that individuals in their 70s and 80s who come in to a general hospital setting could be given a cognitive screening test such as this on admission and at the time of discharge. To do so would shed great light on the patient's ability to function independently in the world in a number of ways, including such things as remembering to take medications on a timely basis. So with that, let's move on to the next slide.
The CAS II provides an expert system guidance software package that interprets many of the subtest scores based on algorithms. In other words, the scores themselves do not get put on a scale for the user to see, but we interpreted each level of score and provided an appropriate clinical guidance statement for the scores that any particular patient might have obtained. So unlike a scale, which simply gives you a score, we're adding some clinical wisdom to the guidance that we give based on scores, but also based on our own many years of experience using Cognistat. The algorithms offer useful clinical information, and it's when you read them, you can see that we're offering suggestions for the clinician as to how to follow up given this score result. We also provide expert guidance regarding any factors, the ones that Jonathan has already reviewed, any factors that are positive. We describe what care the clinician should take regarding those factors, and any CNS-Active medications that were noted and reported. We provide guidance about the implications of a patient being on that medication. Next slide, please. The new CAS II report includes 6 distinct elements. The graphic profile, which you've already seen, the expert system commentary, which I've just described, the MCI index, which I will be talking about in greater detail, the review of identified factors, comments about CNS-active medications, and guidance suggestions for follow-up. Next slide, please. This is the graphic profile. And again, you see this is a typical profile for an early dementia. Next slide, please. This is a typical example of an expert system commentary. You can see that the first three subtests that are interpreted are all within the average range. Constructional ability is somewhat below average, and there's a description of what the score means, about the varying abilities of constructional ability in the general population, and questions about talking to the patient and further evaluation. Memory is more impaired, and it's highlighted in that way. And there's a reminder to rule out possible treatable causes of memory problems, and the request for further evaluation. And then the MCI index statement. This patient has an index of 4. And as we'll go through the various meanings of the index scores, but 4 raises the question of a mixed dementia syndrome, mixed in this case because both memory and constructions are involved. Next. Here are the factors, and Jonathan, you can take this one.
Thank you. This is a particular patient who presented with 3 factors. And as you can see, the person had some significant visual concerns, had problems with balance, dizziness, and some visual scanning difficulties. And if we move to the next page, the next slide, you'll see that the person also, interestingly, had anxiety. Now, fear of falling and sometimes even social avoidance comes about quite frequently in individuals who've had injuries that lead to vestibulopathy or vestibular problems. We have come to find and believe that a significant portion of the 20-plus symptoms that are listed under the heading of post-concussive disorder may derive directly from vestibular injury. These people can, of course, be misdiagnosed as having primary anxiety disorders or having hysteria or a variety of things, but it's important to look at the relationship between and among the different factors. Each of these factors represents an opportunity for intervention, for treatment. And as such, the person performing cognitive screening with a tool such as CAS is not simply in the position of defining or describing cognitive performance at one point in time, but is actually empowered to make suggestions to the referring physician, to family members, to others on a rehab team about things that can be done that will give this person a better chance of recovering and returning to an independent life. Next slide, please. The issue of medications is a big one, and to say it bluntly, there are an awful lot of medications that are out there. Too many medications, in fact, for any individual with or without medical training to possibly remember. Each of them, of course, has its own separate family of side effects and goes by either trade names or generic names. So in order to help clinicians get through this tangled web of polypharmacy, what we have done is identify 12 families of CNS-active medications, and we provide a description in our manual of the common side effects for each of these. This isn't the time to go through all of these, but one has only to mention analgesics, the range of synthetic opiate medications that can be given, to say nothing of high-potency opiates, morphine sulfate itself, dilaudid in hospice or ICU settings, antipsychotic medications that block dopamine and may create Parkinsonian pictures, not only with tremor, rigidity, and slowness of movements, but with bradiphrenia, that is slowness of mental functioning. Then there are steroids that have the potential to create depression, insomnia, psychosis, and the list goes on and on and on. We tried to assist the clinician here by not only identifying these medications, but alerting the clinician to the commonest side effects of these medications. We also talk about drug-drug interactions. So we think that that's another thing that Cognistat Assessment System does to individualize the assessment of each patient. Next slide, please.
The MCI index is perhaps the crown jewel of our algorithms that we've developed and that we've included now in CAS II. It's based on the two most sensitive Cognistat subtests to MCI and dementia, constructions and memory, and you saw how these worked in a typical case of dementia earlier. The index itself is based on a clinical algorithm that incorporates a 5-dimensional matrix. Scores on the constructions and memory subtests, the age of the individual, the number of years of education, and the specific pattern of cognitive impairment that's shown. We constructed these categories, that is the 7 points on the MCI index scale, based on our own clinical judgment. We posed a number of questions to ourselves, Jonathan and I, like, how serious is it for a 63-year-old man with 13 years of education to score a 10 on memory and a 4 on constructions? Those are the kinds of questions we posed over and over again as we worked out the algorithm that could be used for converting scores in conjunction with age and education into a category 0, 1, 2, 3, 4, 5, or 6 on the MCI index. It turns out that the clinical construction of this index has given it not just exquisite sensitivity to MCI and dementia, but a high degree of specificity as well. We have already demonstrated its validity in 4 very different populations. 3 dementia populations, Montreal, Sweden, and Puerto Rico, and an HIV positive population in Los Angeles. These are, each of these showed both the sensitivity and the specificity to a degree that other cognitive screening tests could not even begin to address. Next slide, please. Here's the index, 7-point scale, 0 meaning no impairment. Then we have 3 levels of MCI, so that we're not just talking about mild cognitive impairment as a single entity, but something that has graded levels of concern. And this is exactly what we're doing here, raising the question, suggesting and strongly suggesting. These are levels of concern or probability that are for the clinician. How worried should they be about this particular patient? Then we have 3 levels of questions or worries or concern about dementia. Raising the question, suggesting and strongly suggesting a dementia syndrome. And what we've learned is that these 7 categories provide a very tight rank ordering of risk of dementia. Next slide, please. Here's a patient with an MCI index of 3. And as you can see in this particular case, the MCI index value is exclusively determined by mild to moderate memory impairment. So it's an amnestic MCI. Next slide, please. At MCI index level 4, you more typically start to get a mixed profile with both constructions and memory beginning to show impairment. In this particular case, you can see there's some impairment in terms of language functions and calculations. And as you all know, a dementia can present in a variety of ways. But for the index, it's keyed off the 2 subtests, constructions and memory, which are the most reliably predictive of the onset and evolution of dementia. Next slide. This is an MCI index case of 6. And as you can see, this particular patient does better on some of the language subtests, but is more severely impaired in the 2 subtests that matter most in the assessment of dementia, constructions and memory. Moderate to severe impairment, and the highest ranking on the MCI index strongly suggests a mixed dementia syndrome. Next slide, please. This is a complex slide to look at in the course of a presentation like this, but it shows the very first comparison that we did using the MCI index. And this was with a group of mostly dementia patients with several non-demented patients included, in comparing the MCI index with a comprehensive neuropsychological evaluation. So the clinician who carried out the comprehensive evaluation did all the tests, taking several hours, and made a clinical interpretation of dementia, mild cognitive impairment, or no impairment. And Cognistat generated the MCI index, and the index scores alone were used to compare with the clinical judgment of the clinician. And if you look at the green column, you'll see that all but 2 of these patients are true positives or true negatives in this comparison. Patient number 8 is called a false negative. We said that the mild cognitive impairment was within age range acceptability. This was an 88-year-old man. The clinician who did the comprehensive testing judged that this was mild cognitive impairment. It's not clear that the index was wrong. It's a judgment call. and we split with the comprehensive testing on that patient. The only patient that was truly missed by the MCI index was patient number 12. We said, based on the index, that there was MCI present, and the patient had an obsessive compulsive disorder, and in fact could make errors on memory testing, but actually did not have a dementia. We raised a question on this case since we didn't do the Cognistat testing, whether adequate memory registration was ensured. One of the features of Cognistat from its very beginning was a specific registration procedure that would all but guarantee a patient registered the 4 words for the memory test adequately before being asked to remember them. And in this particular case, it may well be that the 2 trial registration criteria that we use was not adhered to, and we never could find out that. Whether this was one missed or not, the accordance between the comprehensive testing and the index was startling. And what was most startling was that the patients who were thought to have mild cognitive impairment based on comprehensive testing scored at 1, 2, or 3 in the MCI categories on the index, and those who were thought to have a dementia based on the comprehensive testing scored at 4, 5, or 6, the 3 levels of dementia. So we not only have a scale that works, it seems to sort mild cognitive impairment from dementia, as well as both of those from normal. That's the end of my presentation. Next slide, please. We have what we believe to be a rapid yet sensitive cognitive screening test, and an index that has specificity, not just sensitivity, for MCI and dementia. Thank you.
Well, thank you, Ralph and Jonathan. And I'll throw the meeting open now. I don't think I've seen any questions at this stage. And if that's the case, Fortunato, have you seen any questions? No.
No, I haven't.
Okay.
Richard, I could fill the space with a comment or two.
Please.
In my experience, psychologists and physicians don't always see eye to eye. Those among you who are neuropsychologists have gone into this field because you are not lumpers. You're more interested in splitting, in patterns, and in defining subtypes of impairment. One of the joys for me over the last few decades has been interacting with Ralph Kiernan on a regular basis, sometimes face-to-face, usually by phone. But we think in this dialogue between us, something has emerged which is unique and powerful and offers a way to bring psychology smack dab into the middle of medical assessment. And because of our awareness of and concern for shifting factors, some of which are pharmacologic, some of which are psychiatric, some of which are neurologic, and some of which are psychosocial, we believe that we can build a compelling case that cognition, again, is fluid, emergent, and very, very sensitive to a variety of shifting factors. What that means is that any individual giving this test has something very, very special to bring to the medical community and to the family members of these patients. When a person finishes giving Cognistat, it's not that one wipes one's hands and says, next patient for screening. It's rather that a series of questions have arisen. These in turn can be posed, but alongside these questions, there's something that's awfully important, and that is hope. Every time one gives Cognistat and identifies one or more factors, one is in a position to tell the daughter, the spouse, the parent, the care providers that it's really important that we try to see if we can lower the number of medications this individual's taking. He seems to be taking 2 different medications for sleep from different care providers. They may not be aware of this, or there are too many pain medications on board. Each of these things means that there's something to look forward to and something to do. It's not over and done. It's not cognitive pathology writ in concrete or marble. It's rather a dynamic living system that one is interacting with. I dare say that the 3 cognitive screening tools that I mentioned at the outset do not give one any intimation of the possibilities that exist for intervention, treatment, and rehab. So it's one thing to be a diagnostician. It's another thing to participate in and be proactive in terms of treatment and scanning those options.
Okay, thank you, Dr. Mueller. I think at this point we can end the webinar. I want to thank all of our guests for joining us. I want to thank our presenters, and we'll let you know that this webinar has been recorded and will be available within a few days on the Cognistat website if you should wish to see it again. At this point, I shall bid you all goodbye and thank you.